Okay, it's already recorded. And let's start with a prayer first. In the name of the Father, and of the Son, and of the Holy Spirit. Amen. May the Holy Triune God live and reign in our hearts and in the hearts of all people. Amen. May the darkness of sin and the night of unbelief vanish before the light of the Word and the Spirit of grace. May the heart of Jesus live in the hearts of all people. In the name of the Father, and of the Son, and of the Spirit. Amen. So, if I guess you still remember about this pyramid of evidence. So today we will learn about systematic reviews and meta-analysis, which are on the most top of this pyramid or this triangle. The systematic reviews and meta-analysis can be said as secondary research, as they use the available articles or available research reports from the primary research, and they try to create an evidence to usually to provide a direction or a decision to based on our best current knowledge. This is really helpful for practitioners in providing the evidence-based medicines. So if you heard about the jargon evidence-based medicines, it should be correlated with, or it should be related to the systematic reviews and meta-analysis. But mostly the researchers who conduct systematic reviews and meta-analysis will select randomized clinical trials, but there are some systematic reviews or meta-analysis that use the observational studies such as cohort studies, case control, cross-sectional, but especially the cohort studies, because the evidence is better than the other observational studies. So let's have a look to the definitions. Meta-analysis can be defined as the statistical analysis of a collection of analytic results for the purpose of integrating the findings. So this meta-analysis, like the although it is not written here, but usually is used to define the synthesis of quantitative studies, results from quantitative studies. There is a different term if we want to synthesize research that use the qualitative designs. It is called as meta-synthesis. So meta-analysis is for quantitative studies, while meta-synthesis for qualitative studies. Meta-synthesis come with many synonyms, such as meta-aggregative reviews, and then meta-ethnography, and so on and so on. So there are a lot of names for meta-synthesis. But for meta-analysis, as far as I know, it is only called as meta-analysis. Okay. Another uh, another definition is the statistical combination of quantitative evidence. This is explicit, that mentioning the quantitative evidence from two or more studies to address common research questions, where the analytical methods appropriately take into account that the data are derived from multiple individual studies. So in this definition, aside from describing that the meta-analysis is to synthesize the quantitative evidence, it also provides a clue that the minimum of the minimum number of studies that can be synthesized are two. So two studies are enough to create the meta-analysis. And meta-analysis is a statistical approach using some types of statistical methods to to synthesize, to create new knowledge from the existing knowledge. Meta-analysis may have a qualitative component. This may include the classification of studies according to predetermined characteristics capable of influencing results, such as study design, completeness, and quality of data, and also absence of biases. So this is the qualitative part of the meta-analysis. So it is not about the quantitative uh, quantitative part of the results, but about the assessment of the quality of the study design and so on. So this is usually this qualitative component is also usually being reported on the paper, and also that it has also quantitative component, the extraction analysis of the numerical information. So don't be confused with the meta-synthesis that I mentioned before. The meta-synthesis is to create evidence from the existing knowledge derived from the qualitative studies. So, so I hope you're not confused with this term. But if you are confused, just let me know by asking the question. And then the systematic review. So usually researchers that conduct meta analysis will do systematic review first, because they need to do a systematic search, systematic screening, systematic assessment to the full text, and so on, before they got the included articles that will be analyzed using meta-analysis. Systematic review is a review that summarizes the results of available carefully designed healthcare studies. This means the randomized controlled trials, and provides a high level of evidence on the effectiveness of healthcare interventions. Healthcare interventions can be in the form of testing the effectiveness of one drug compared to a new drug compared to existing drugs. It can be also in the form of testing the current uh, approach, for example, pharmacy service, a new pharmacy service compared to existing pharmacy service and so on. So healthcare interventions are a very broad topics and can be anything as long as it has intervention. But as remember that uh, systematic reviews or meta-analysis can be also done for observational studies, not only the RCT. So although I provide some definitions here, the definitions may not really, you know, cater all existing meta-analysis and systematic reviews that are available nowadays, because the knowledge, the methods are always developing. So, like what I said before, meta-analysis can be conducted using results from randomized clinical trials or randomized control trials. And from this type of meta-analysis, we can draw a causation, we can draw a causal relationship, while for observational studies, we can only draw the association. So that's the difference between both of them. And there are some, excuse me? Okay, so there are some, that's okay, that's okay. There are some methodology problems to be solved by pharmacoepidemiologic research in meta-analysis. First is the susceptibility of the original studies to bias. The second is combinability of studies, publication bias, and bias in the abstraction of data. So yeah, there are some. If you have looked to this list, all is related to bias, and I hope you quite understand about the meaning of the bias. Bias is, in short, bias is a systematic error that can occur in many steps of research, many stages of research. So, yeah. So, in doing systematic reviews as well as meta-analysis, the researchers need to aware of this bias in the original studies that will be synthesized. It is related to the study quality, and or it can be, and sometimes this is termed as the susceptibility to bias or likelihood of bias or risk of bias. Fortunately, there is a tool that is developed by the Cochrane collaboration called Robbins I. This is risk of bias in non-randomized studies of interventions. So I think this software is provided for free, if I'm not mistaken, because because Cochrane is a non-profit organization. And this assessment of bias is very important step before doing the synthesis. So in this assessment, we need to exclude those articles, those papers that cannot meet the cannot meet the bias assessment criteria. So meta-analysis is said prone to rubbish in, rubbish out. So as long as we can select the best articles, the best materials, then there is a guarantee that our results will be good. But if it is contaminated with uh, uh, you know, I don't want to say bad, but it's with the low quality of studies, then our results will be also contaminated. So as big, you have to remember that the main principle of the quantitative review like this, or even the qualitative uh, synthesis in metasynthesis, they always want to make sure that the studies that they include are very good. I mean, in acceptable quality, so that the evidence that is drawn from the process will be uh, will be good, will be useful as it is. I mean, as it's supposed to be. If there is a contamination, then the conclusion or the evidence suggested by the study will not really strong and will create confusion or even, you know, uh, even create a controversy in the practice. Although controversy is sometimes useful because sometimes we need to abandon the old practice and we need to renew it with the new practice based on the current best evidence. But if then the new evidence is not supported by best best studies, then you know it will be very debatable. And as a researcher, it will jeopardize the our credibility as a researcher. In the future, we will we will be struggle if we want to publish evidence from this type of study. That's what I know. And then the combinability of studies. So different studies or different study designs will look at different outcomes with different treatment in different patients. So there are some cautions when we want to combine or we want to include uh, the studies into our meta-synthesis or systematic review or meta-analysis. So, for example, the uncombinable studies are studies of hormone replacement therapy in relation to risk of breast cancer with studies of hormone replacement therapy in relation to risk of coronary heart disease. So, because they use different types of hormone replacement therapy, although the name is hormone replacement therapy, then even though it's just this, but it's really depends on the research question. But you know, in this example, it shows the really different outcomes that the first one is the risk of breast cancer. The second one is the risk of coronary heart disease. So it will be okay if, let's say, for example, we have the big risk, or you know, the we our study will focus on the these adverse effects of hormone replacement therapy. However, usually meta-analysis will be very specific in terms of outcome. We don't want to have a big topic or big outcome to uh, to analyze. So yeah, although it depends, really depends on the research questions that we want to answer, but usually the meta-analysis will ask specific questions. So if we want to know the risk of breast cancer from hormone replacement therapy, so just stick on that topic. Do not mix with studies that uh, that research the hormone replacement therapy and the risk of coronary heart disease. That can be two different subjects. Okay. And then should studies with different patient populations be combined in terms of, for example, race, and then the ratio of the participants, men and women, and so on? Yes, it can be. But I think as long as the original studies mention the characteristic of the patient's populations, then we can be aware of the dif different of the differences or the heterogeneity of the articles uh, that we want to synthesize. And then how different can this population be before it becomes unnecessary to combine the studies? We have to ask these questions as well. And then should different hormone preparations be considered as being equivalent, and so on? Should non-randomized studies be combined with randomized studies? These questions require judgment really. And usually it is okay to combine non-randomized studies with randomized studies, but it should be noted, or we should find uh, the reason for this uh, answer, for this question, to explain this question. Uh, the problems of the combinability occurs because every study tends to have the novelty or uniqueness that uh, will be offered to the scientific community, right? So no study will have the same research question, or will have the same, uh, you know, the same design and so on. So that's why we will find variations for the for the articles or publications that we will want to analyze, we want to synthesize. So it is normal, but it depends on how we provide the reasons to combine one study with the other study. It is very important step, and also it is not easy. That's why meta-analysis or systematic reviews cannot be done by only one researcher. It needs more than one researchers. I don't say that you know, many uh, uh, at least two researchers, but nowadays there are many in a group of, usually it consists of four, three or four or even more than that for the, the authors of meta or the researchers on meta-analysis or systematic reviews. Just sharing that right now I'm doing a meta synthesis. It's not meta analysis, but meta synthesis. And I discuss a lot with my colleagues to define which paper should we include and so on. And even though we have a good inclusion criteria and exclusion criteria, sometimes there is a gray area that we need to be aware of. And so it needs a lot of discussion, even before the analysis and before the synthesis. And then the publication bias. This occurs when study results are not published or the publications is delayed because of the results. So publication bias is like sometimes researchers who found negative results in their RCTs do not have eagerness to publish their studies, because usually studies with negative results are not are less interesting than studies with positive results. But actually, in my opinion, we need also the negative results that to be published, because it may it will still contribute to our current understanding, our current knowledge. And sometimes publications is delayed because of the process, because of the review process by the editors or the reviewers of journals. So let's say if we conduct a meta-analysis this month, for example, and then we first we search and collect studies that are done months or years before, then some papers that will be published next month or in the next 2 months and so on will not be included in our studies. And so this creates a kind of publication bias. And if our study is conducted earlier, depending on the steps that we have done, if we already start the synthesis and even we already draw the evidence, it it may become quite hard to include the new studies, although it is possible as well. But you know, we need to validate our search results, search strategies, and so on to make you know to make us having more probability to have more new studies to be included in our uh, research. I hope you understand this. So, yeah. And then also the registration system for RCTs. Uh, some, do you know the registration system for RCTs? There are some registries that are dedicated to uh, dedicated for researchers to register their proposal of RCT, like the Prospero. You can check the Prospero website. But Prospero is only one of the RCT registries. So there are also a registry provided by the US government. And yeah, so there are some registry. And some of the RCTs, currently many RCTs are already registered before the researchers conduct the study, but in the past, probably not all randomized clinical trials are registered to these registries before they are conducted. So yeah, and it becomes sometimes it makes us want to exclude uh, the the study, but yeah, it become one type of the publication bias. And then the bias in the abstraction of data, the risk of observer bias when the data from all original studies present, and then the disagreement between observers, and then the acceptance of rejection of different sets of studies can drastically change conclusion. Yeah, so uh, this is actually also an important step and not easy. It's quite challenging if you already have the studies and you have all the data, and sometimes it's not easy to uh, the observers here are the researchers that conduct the meta-analysis, and sometimes there are disagreement between observers, and it is usually solved by consensus or probably recalculations or using a different uh, yeah, calculation methods and so on to find the solutions. And sometimes uh, if yeah, we accept or reject some sets of the studies, then it will lead to different conclusions that will lead to different evidence provided by our studies. So having a solid, good team, although we need to, uh, to give the space, the room for different opinions, but really having a good research team is very beneficial doing all the process in the meta synthesis. So as the solutions is that there are internationally accepted guidelines. I've introduced to you this uh, website, the Equator Network, in the, I don't know in which meeting, but I already told that. Just try to Google Equator Network. In Equator Network, there are a lot of standards of reporting for different methods of clinical studies. And for uh, systematic reviews and then meta-analysis, we follow the Prisma statement. I think the newest Prisma statement is released on 2020 or 2021. I forgot. Yeah, 2021. I forgot, but there is a newest version of the Prisma statement. So just follow this uh, guideline and follow the steps, and it should be, and our research will be okay. And the second one is the Cochrane Handbook of Systematic Reviews. And also there is one more, the Joanna Briggs Institute, that is, I think the institute is in the University of Adelaide. So actually, Cochrane and Joanna Briggs Institutes start at the same time. They are focusing on providing assistance or providing, the standard for researchers to conduct uh, reviews in many types of reviews, a lot of types of reviews, and especially the metasynthesis systematic review. So this is the steps to conduct meta-analysis. So the first is defining the purpose and then performing research, establishing inclusion and exclusion criteria, collect the data, perform statistical analysis, and formulating conclusions and recommendation. So we can use, sorry. So the first one is to define the purpose, or I said before, the research questions. What we want to know from the meta-analysis that we will conduct. We can use the PICO framework to help us formulate the question, the research questions, as well as the purpose of our study. So PICO framework, I hope you are familiar with this. If not, PICO is a short form of the population. P is for population or patient problems. And then I is the intervention, C comparator or control, and O is the outcome of interest. And then some people may use PICOTs. The T is timing and S is study design or setting. We have to be clear of our purpose of our questions, because with this, because we will then, this will guide our selection of the articles, or to establish the exclusion and inclusion criteria. This will guide us to judge whether the studies should be included or not, and so on. So, yeah, for example, here is what is the magnitude of the increased risk? So, increases of gastrointestinal side effects with NSAIDs used for the treatment of pain compared with placebo. So in this situation, it is specific that we won't only pursue the magnitude. We just want to know the magnitude because we already know the increased risk of gastrointestinal side effects with NSAIDs. And then we use the NSAIDs. We have to define what non-steroidal anti-inflammatory drugs is paracetamol included in there. Will paracetamol be included or not? And so on. And then for the treatment of pain, the use of NSAIDs for other treatments such as aspirin for the low dose aspirin to reduce the risk of heart disease will not be included in this study. So this question must be clear. And then the second one is conducting the literature search. This is an early, early and important steps. Sometimes we need to consult with a librarian because they are more familiar with such strategies. And the problem is not all databases use the same, the same search strategies or search keywords, or every database offers their own way to search or to retrieve the existing data in the database. So we have to be aware of this. For example, if we want to search via Ovid database, it will be different with searching via EBSCO host. It will be different if we search via Scopus and so on. Each of them has their own, strategy, and we need to know this strategy. So non-specific term can result in a large number of mostly irrelevant citations. Too many restrictions can result in missing a substantial number of relevant publications. So just for an illustration, like what I said before, I'm doing a meta-synthesis. It took me a lot of time to formulate the search strategy, and eventually I found about 2,000 plus articles, while after narrowing down by abstract screening, the title and abstract screening, I just found 74 full text articles that probably met the inclusion criteria. But then I, read the full text and so on, and only found 11 articles. So this is exhaustive. The search is not exhaustive, but you need to be aware of your steps and so on. But after this, it will be exhaustive before we start the synthesis. And then we need to establish inclusion and exclusion criteria. This is rules to include or exclude the studies. Sometimes we have some criteria that already fixed in the beginning of the study, but when we screen the articles, then we may sometimes found another exclusion criteria or inclusion criteria. and then collecting the data after we have the decision to include which article we want to include, then we will start to mine the data, to collect the data from the papers. So yeah, data abstraction forms should be created first, and then yeah, you know, we will then take the data and do the statistical analysis. So in meta-analysis, we measures the effect size uh, if the outcome of interest is binary, yes, no, yeah. Binary, like the outcome may contain yes or no, or cured, not cured, dead, alive, and so on, using the relative risk odds ratio or risk uh, difference. The statistical procedures can use the Mantel-Hansel procedure to combine the odds ratio of that are, you know, presented in the studies. And then there are some statistical packages like Refman as well as JASP. Both of them are free in my understanding, but I'm sure that JASP is free because I used it several times in the past. Yeah, and then after that we draw conclusions and provide recommendations. This is the case studies. I think you can read by yourself. Yeah. So, is there any questions for you from you? Is it quite clear? Hopefully. Okay, there is a question. Oh, none so far. Okay. Okay, I think I stop my presentation here. And thank you for coming. And see you next week. Bye.